Welcome to part one of the audiocast, The Need for Patient Optimization in Joint Replacement Patients. My name is Bruno Capella, and I'm a Managing Senior Director at Accelero Health Partners. Joining me today is Sue Miller. Sue is a Senior Director for Accelero with a strong experience in joint replacement. Sue has implemented joint replacement programs across the country, including outpatient joint replacement. Sue, there's so much pressure today on pay for performance. And the key is performance, which really equates to outcomes like managing length of stay, improving patient satisfaction, and really reducing complications. When it comes to joint replacement, what do you think is the best strategy to really make that happen?
An area of opportunity that I consistently see across partnerships is really the preoperative readiness of orthopedic patients. And when we speak about preoperative readiness, it's a combination of patient selection, education, as well as optimization that will truly help your service line to get the best possible outcomes. The best programs will marry all three of these different elements. It's not an either-or concept, but really a comprehensive approach. So first, as we consider education, it really is the rare orthopedic program that does not have some form of education in place for their patients. So I find that this idea is really well understood and well applied. Second is the patient selection element. Patient selection really is part and parcel of a broader patient optimization program. If you were to try and tackle patient selection without having the patient optimization process in place, you run the risk of merely narrowing your potential pool of patients and appearing to be difficult or hard to work with when you consider the referral source perspective. Patient selection without having that defined method, in essence, is really just saying no. So let's focus on the optimization. This is really the best opportunity to ensure quality and consistent outcomes. It's a common sense approach. When you think about your patient, it makes sense that the better the patient is going into surgery, the better the patient will be coming out of surgery. Keep in mind that optimization is not a fix for the patient or curing all that ails the patient, but rather it's helping the patient to be the best in terms of the healthiest that they can be. So it's taking a proactive approach to post-operative problems. You're really being a fire preventer versus a firefighter. And really when it comes down to it, avoiding complications is the best way and the cheapest way to manage your costs.
So here at Accelero, we've probably evaluated 300 plus joint replacement programs across the country and internationally. We see many issues, and we've defined a lot of opportunities for those hospitals to improve their programs. What are some of the challenges you're seeing here and now in the field when you're working with hospitals as it relates to this concept of patient optimization and readiness?
Two of the challenges that I see and immediately come to mind are fragmentation and then ownership of the program. So when you think about fragmentation, this is really an initiative that will require significant collaboration, coordination, and communication, the 3 C's. It sounds simple, but it's not always an easy task to accomplish, especially when you're in a large organization and there's diverse employment and compensation models where care providers potentially could be aligned to different goals. All of these goals are well-meaning when they're viewed individually, and they all make sense, but when you put them together collectively, sometimes you can run into conflict. Sometimes I've had the experience where there are limitations with different providers using different EMR systems and the ability to share that information across platforms. If you were to add specialist care as well as chronic care management of the patient, you really are looking at the potential for a recipe for disaster. Couple that with the fact that all of your different surgeons will have a different process or protocol in place, and the situation can become very unruly. So once you get past that fragmentation and you decide to do this, the next thing that you have to tackle is, well, who will own it? So from an ownership, you really have to define whose responsibility will this be. And what we have seen is really it's best if the hospital takes ownership of the process. From a surgeon's perspective, they really can care for and assess the patient from a surgical procedure, and really are not the best resource for optimizing the patient medically. When you think from the primary care physician's perspective, it's a little bit of the same thing. The primary care physician really sees this as the surgeons or the hospital's issue, and they really have the most to gain in the process and really should control their own destiny. Then internally, you have to consider where will it sit and who will own it within the hospital. Most frequently, what we see is that the hospital will choose to have this within anesthesia or potentially a hospitalist group. Sometimes we'll see a matrix position where the mid-level or a medical provider, medical practitioner will have a dotted line reporting structure to anesthesia or surgery. And then lastly, a model that we've seen in smaller markets or closed system is one where the primary care physician really owns that. And that really only works, again, in those smaller markets or closed system where you can have significant control over it. And again, I'll reference those algorithms and guidelines that you would have to have those in place, and you would have to have primary care agreement to utilize those for that model to be effective.
So you're talking about ownership, right? And you talked about this, you have surgeons, you have anesthesia, you have the medicine docs, and sometimes you have mid-levels. All of these folks may be in different camps in terms of what their position is when it comes to optimization. Talk a little bit about the challenges from that perspective.
It's important to keep in mind with optimization, you really are evaluating and risk stratifying your patients in 3 different areas. You will look at the surgical risk, you'll look at the anesthesia risk, and you'll look at the post-operative or the medical risk. And typically what we find is that the focus in the pre-admission departments is assessing that patient for the anesthesia risk. And then again, the surgeon really thinks about it from a surgical risk and just getting through the procedure. All of those factors really can influence how well or how poorly your patient will recover. So hospitals need to coordinate all of these efforts and view the patient holistically and come up with the best plan for that patient. Sometimes that will mean that you need to take additional time to fine-tune your patient, if you will, preoperatively. And everyone has to agree at the onset that the patient will come first, and all decisions will be made with outcomes as the primary driver and the #1 concern.
So let's turn our attention on implementing a model for a second. And there are a multitude of ways to skin this cat, right? Implement a optimization model at a hospital, right? Different hospitals, different programs across the country will all require somewhat different of approach, right? We know we can't just go in with a cookie cutter approach. What are some of the key considerations that you need to think about when looking at the right model in a potential hospital target?
You bring up an excellent point. This is definitely not a one-size-fits-all problem or fix. So key considerations, I would start with really defining the scope of the project. So think about whether you want this to be a process for all of your patients or only your high-risk patients or only patients within a certain service line potentially. Then I think you have to think about who will be the primary resource. We have seen models where this resource could be a nurse practitioner or a physician's assistant. We've seen CRNAs, we've seen hospitalists. So it's important to understand how this resource will be perceived by others within the medical community. So our primary care physicians, surgeons, specialists, open to feedback and recommendations from mid-levels. Beyond the resource, I think frequently that you'll see physical space can be a real factor as well. So how can you do this without having to rebuild or completely disrupt your current pre-admission department? Another consideration would have to be the communication. process. So many times I have seen instances where great information and planning is happening preoperatively with these patients, but that information is not effectively or efficiently making it to the nursing or case management resources. And if that's the case, the information may as well, and the process may as well not have happened. So it's important to really tie all of your loose ends up. And then finally, I think the last thing to keep in mind as you take on this project is the idea of the cost. And so frequently, that's the immediate barrier that's put up. This is going to cost a lot of money. And as you had mentioned, there's so many different ways that you can implement this, and they will all work and be effective. Many of those are cost effective, so it's important to not let cost be a driver and be the barrier that stops the whole process in its tracks.
This concludes part 1 of our audio cast, the need for patient optimization in joint replacement patients. Please join us for part 2 of the audio cast.